So the BCL2 protein and the other members of the family of BCL2 proteins are survival factors for lots of different cancer cells. So it's a very common mechanism for cancer cells to evade the treatments that we attempt. So in myeloma too, the studies have shown that these myeloma cells have high expression of the BCL2 protein as well as other proteins like BCLXL and MCL1, all of which help the myeloma cells survive. So the BCL2 inhibitor has been designed specifically to inhibit the function of the BCL2 and allow the cells to go into apoptosis. So by kind of triggering that mechanism, we are able to kill the myeloma cells. So venetoclax has been studied as a single monotherapy in patients with relapsed myeloma in a phase 1 study. 66 patients were enrolled, out of which 30 patients were on dose escalation phase, 36 patients who actually got the recommended phase 2 dose. Overall, the drug was very well tolerated. The major side effects that we saw included hematological toxicity, which could be managed with dose reduction, as well as some gastrointestinal toxicity that could be managed with symptomatic therapy. The efficacy indicated about a 20% overall response rate, but when we look at patients with 11-14 translocation, that is about 41% for overall response rate. Even digging deeper, if you look at the patients with a favorable profile, what we call a high BCL2, low BCLXL expression profile, those patients actually had over 80% response rate. Basically what it indicates is we could potentially have a biomarker-driven therapy for myeloma for patients who fit that particular profile. The selinexor is a new class of drug that is being studied in myeloma. It's what is called a nuclear exporter inhibitor. So it actually prevents many of the proteins from exiting the nucleus and doing its normal function. What we have seen with the single agent is that the efficacy in patients who have seen a whole bunch of different drugs, like resistant to bortezomib, lenalidomide, pomalidomide, carfilzomib, and also daratumumab, you can find almost 20% of those patients can get a response with the selinexor. Now, selinexor has also been studied in combination with carfilzomib and as well as bortezomib, and both those combinations actually the drug is tolerated much better. The major side effects are gastrointestinal and also hematological toxicity. So overall, the activity both by itself as well as in combination is very encouraging. So it's a totally new frontier for myeloma, the whole area of minimal residual disease testing. It's been done for years in leukemia, and it's kind of coming to the forefront in myeloma as well based on the data from many of the recent trials. What is happening is we have very effective therapies, so we are getting deeper responses. So the MRD assessment actually makes sense today than it did 5 years ago. So the response criteria has been revised to actually include the minimal residual disease testing either by flow or sequencing method. So what we know from the trials is if you get to MRD negative, patients do very well. What we don't know yet is if somebody is MRD positive, giving them extra treatment to make them MRD negative is actually going to change their outcome. So those clinical trials are currently being planned.